Good morning. My name is Bill McGee, and I'm an associate professor at Tufts. And today I'd like to speak with you about arterial pressure cardiac output and an application using stroke volume and stroke volume variation to take care of patients in the intensive care unit. And I'm going to start out by going through some of the research that's been done looking at these dynamic variables of fluid responsiveness. I'm going to talk specifically about some of the research that I've done, and then go through several cases where we apply this algorithm that's been developed by myself and my group in the ICU at Bay State Medical Center in terms of specifically taking care of sick patients in the ICU. By way of disclosure, I do want to mention that I am a speaker for Edwards Life Sciences, who makes hemodynamic monitoring equipment. We're going to talk about stroke volume variation, specifically during positive pressure ventilation and how it's used to predict volume responsiveness. And we're going to look at arterial waveform analysis as a way of giving stroke volume and cardiac output data that has some advantages over thermal dilution, specifically that you can measure it really on a beat-to-beat basis. You're getting feedback in real time as you look at patients. These variable measures are considered dynamic parameters because they change rapidly over time and they can predict the future. The static measures that we're used to, central venous pressure monitoring and pulmonary capillary wedge pressure, really tell you what's going on now, but make it difficult to predict whether or not the patient will respond to a volume challenge. And one of the things we like to do for sick patients in the ICU has to do with resuscitation. And what may seem simple at first glance may not be that simple, primarily related to the interaction between the heart and the lung. So a common goal is to give volume until the hemodynamic function is optimized. Well, how do we judge that? We need to individualize it because all of our patients are different. There's a lot of things going on with the heart that may change dynamically related to ischemia, loading, afterload, and vascular tone. And then there's issues related to cardiac compliance that will change also related to rate and blood pressure. We've all learned that there's a big interaction not only between the heart and the lungs, but also between the right and left heart. That will affect not only volume, ejected volume, but also affects the pressures that we measure. The impact of the ventilator on both the heart and the lungs may change dynamically based on what we're doing with the ventilator, and also based on how the patient's disease process is changing with mechanical ventilation or a disease like ARDS over time. Venous capacitance is a dynamic variable that we don't measure. It's actually pretty hard to put a finger on, but the venous capacitance circuit is really much greater than the vascular circuit, the arterial vascular circuit. And depending on what's going on there, can affect the preload of the heart pretty dynamically. So the concept is that there are multiple Starling curves, not only across the spectrum of patients that we see, but also within individual patients at any point in time during their disease. So although it's nice to draw a Starling curve and try to figure out where your patient is on that curve may actually change over time. So the initial concept of to give volume until the patient is optimized may not be that simple, and certainly can be difficult in the setting of critically ill patients. So I've drawn the Frank Starling curve here just to talk about some of these things as we look at the relationship between preload, LV filling, however you want to measure it, by volume or pressure, and some measure of LV output, cardiac output or stroke volume. And we know once you get beyond a certain pressure that fluid starts backing up in the lungs and you get pulmonary congestion. And that may be different for someone who has an acutely failing heart with an acute MI, or someone who's now accommodated to that with chronic heart failure. Depending on our therapies, decreasing afterload, trying to improve contractility with inotropy, interactions with the ventilator, and specifically what the preload status is of the patient. Our position, or the patient's position on this curve, may also change. So there's lots of interactions between the patient, their physiology, and our treatments, which would move them along the curve and also change the curve that they're on. And all you really need to do is to go back to basic physiology, and I got this from Guyton's textbook of physiology, and he clearly shows that there's multiple curves and emphasizes the point that patients may actually jump between curves as we treat them or as their disease process changes. What we're trying to do is to optimize their position on that curve for sick patients in the ICU, and that may not be simple. Over the last 10 years, there's been an increasing interest in these dynamic variables of volume responsiveness, and this data now exists that really can kind of pinpoint where your patient is on any one of these Starling curves and allow us to predict how they will respond to one of the most common interventions in critically ill patients, and that's giving a volume challenge. Back when I was doing my training, there was some talk about CVP monitoring, and it kind of went out of favor in the critically ill patient as a predictor of volume responsiveness because of all the things I've already talked about in terms of the interaction with the heart and the lung. So pulmonary hypertension, whether it's acute or chronic, acute pulmonary embolus would be an example, would raise the CVP but may not reflect filling of the left side of the heart. What's going on with the ventilator, what's the mean airway pressure, how much of that pressure gets transmitted to the heart, and the contribution of PEEP to that also will affect the CVP measure, and again may not really reflect what's going on the left side of the heart. You need to consider what the lung compliance is. Does the patient have very compliant lungs like emphysema, or are we dealing with stiff lungs, ARDS, and again how much that pressure gets transmitted to the heart. The example I like to train my fellows on is tamponade, where the pressure's high yet the preload is low. So basically the way I train, any heart or lung disease impacts the utility of CVP monitoring to predict where the patient would be on their Starling curve. And this has been proven again, and it's interesting, in medicine a lot of things come around on maybe a 15 to 20 year cycle. But this is a series of patients with septic shock, published in Critical Care Medicine back in 2007 by Osman, looking at pulmonary artery occlusion pressure, or CVP, and its ability to predict a 15% increase in cardiac output. These patients were all given 500 cc bolus of Hespan to rapidly expand plasma volume and to see if knowing what the preload was would predict whether or not the patients respond to volume. And as you can see from the slide, R being the responders and NR being the non-responders, there was no discriminating value of either pulmonary occlusion pressure or CVP that would predict ahead of time who would respond to this type of volume challenge. So again, that's the beauty of basic physiology. What Guyton said originally has not changed. And this table just reflects 16 of these studies that have been published in the literature that all basically say the same thing, that knowing a static measure of preload, and here we're using right atrial pressure, pulmonary artery occlusion pressure, or even right ventricular end diastolic volume index, and we're judging the responders the same way, greater than 15% increase in cardiac output, and does knowing that data ahead of time predict whether or not the patient will respond to fluid? And you can see, with the exception of 2 studies, that knowing that data ahead of time does not predict whether or not the patient will respond to a volume challenge. So really what I want to focus on going forward now is looking at these dynamic variables of fluid responsiveness, which I'm going to show you through a series of experiments, have a much better ability to predict whether or not your patient will respond to volume ahead of time. So in our ICU, you can see we've eliminated CVP monitoring. We've also eliminated bed sores with this technology. But the primary objective of you listening to me talk about this today is to look at these dynamic changes in stroke volume during the respiratory cycle. And most of the conditions for these experiments are done under positive pressure ventilation because it's the best control to regulate the change in pleural pressure, which then regulates the amount of blood that's coming into the chest and then going out. So when you look at the data, this produces the cleanest data. And it also determines a unique point on the Starling curve. So it's really a way to individualize where your patient is on their own curve. Stroke volume, obviously, is generated by the output of the heart on a beat-to-beat basis. And some of these studies look at pulse pressure, which obviously has been generated by that stroke volume that's been ejected by the heart. It's fairly simple to conceptualize, and I think we all learn this by standing at the bedside of hypovolemic patients, especially those who had wide swings in pleural pressure, and status asthmaticus is really a good example of this. But if you look at a hypovolemic patient, and I learned a lot of this from nurses in the cardiac surgery ICU, when the patients came up from the operating room, you could look at their arterial waveform and see it go up and down as the ventilator cycled. You could even feel that in the pulse. So we've all seen this, and there are some examples in spontaneous breathing, which we're going to talk a little bit about, because again, most of the data is on positive pressure ventilation. But pulsus paradoxus, which was described in the 18th century, is an example of this in spontaneously breathing patients. Greater than 10 millimeter change in blood pressure related to respiration. It's more common in patients who are hypovolemic. It's easier to see, especially if they have wide swings in their pleural pressure, like status asthmaticus. And again, tamponade, I think, is really one of the best examples of this, where the pressure really shows you the exact opposite of what's going on with the volume and cardiac performance. But there are these well-known examples in spontaneously breathing patients. So this slide kind of summarizes exactly what's going on. In the top frame, there's airway pressure on the ventilator. So there's 4 positive pressure breaths. Below that is the arterial waveform. And you can see the blood pressure is going up and down as the ventilator cycles. So what's happening here, as the ventilator cycles, the pressure inside the thorax is increasing. So what that does acutely is it increases the afterload on the right ventricle and simultaneously decreases preload. So it keeps the volume from coming into the chest. And this is kind of a concept that we all learn taking care of mechanically ventilated patients. At the same time, though, it's pushing volume over to the left side of the chest and then acutely increasing the stroke volume as the ventilator cycles. And it also has some impact on LV afterload, which is decreased as the ventilator cycles also. So during inspiration, you see this augmentation of systemic pressure. What you're left with, however, is an empty pulmonary venous system. So several beats later, during expiration, you see this decline in blood pressure. And all the physiology I'm going to talk about today that looks at dynamic variables of volume responsiveness really uses this basic physiology that we all understand. So here's a single example in a patient with ARDS during a 500 cc fluid bolus. In the first frame, if you actually measure the pulse pressure variation, looking at systolic minus diastolic from the peak blood pressure to the minimum blood pressure, there's a change there of about 27%. And you can see the airway pressure is superimposed on the blood pressure. That's exactly what it looks like. This patient then gets 500 cc's of saline. And not only does the blood pressure come up fairly dramatically, but the pulse pressure declines pretty significantly. And all the physiology we're going to talk about really emphasizes what you see in these 2 frames right here. So some of the terminology that I'll be using interchangeably, and you may read in the literature, looks at stroke volume variation, pulse pressure variation, or just simply systolic pressure variation, just looking at the peaks. And the variability is very dependent on the volume status and the delta pleural pressure, which is primarily determined by two factors. What's the lung compliance? So does a patient have very compliant lungs like emphysema, or do they have something like ARDS where the lungs are stiff? And then the way you ventilate the patient. What's the tidal volume and how much PEEP is the patient on? So all these things that interact with lung compliance will change the amount of variation you see depending on the disease and the ventilator. Some of the other things that we're going to talk about that also impact that are the cycle length, and that's why when you look at these studies, the patients are paralyzed and ventilated, typically somewhere between 10 and 20 breaths per minute. If the cycle length for the breathing is irregular, that's going to phasically affect the filling of the heart, and the variability will change simply related to that. Depending on what's going on with the heart, how compliant is the heart to accept this volume also impacts the variation that you're going to see. So a totally failed heart may have less variability. Patients with acute pulmonary hypertension and a failed right ventricle, there may be a lot of variability going on in the systemic circulation. In those patients, however, fluid challenge may not help because the right ventricle can accept that volume and not change its output. The paradoxical pulse that we've already talked about in severe asthma and tamponade are examples of this phenomenon during spontaneous breathing, and I like to continue to emphasize that because these are things we're all familiar with. And interestingly, or importantly, for using this physiology at the bedside, the variability is increased when the patient's hypovolemic. So here's an experiment looking at superimposing this physiology on the typical Starling curve. And just to kind of set the stage here, this is during one ventilator cycle. The end diastolic volume change here, the preload change, is identical. But depending on where you are on this curve will determine how much variability you get in the stroke volume. So this is a great example of superimposing this physiology, stroke volume variation and stroke volume, on the better-known Starling curve and showing how you can individualize the patient's position on that curve by simply looking at the variability. So there's no difference here in the amount of volume that's given or obtained. Might be a better way to look at it because this relates to one ventilator cycle. And you can see if there's a large variation, the change in cardiac performance as measured by the stroke volume will be greater than if there's a small variation. So it's showing how the Starling curve is individualized by using this relationship. So I'm going to go through a couple of studies now which utilize this physiology in treating patients that are critically ill. The first one is by Michard and appeared in the American Journal of Respiratory and Critical Care Medicine almost 10 years ago now, looking at the impact of PEEP on cardiac performance in ARDS. And he looked at the ability of the variation in the arterial pressure during positive pressure ventilation to predict a subsequent increase in cardiac output in patients with ARDS in the first study and then severe sepsis in the second study. So on the y-axis here you have the delta pulse pressure without PEEP. And on the x-axis, they added 10 centimeters of water of PEEP, and they wanted to see what the change in cardiac performance was. And you would expect the cardiac performance to decline. So not only did the cardiac performance decline, it declines in a linear manner. And when you look at a lot of these studies, not only is it remarkable for the impact of these variables on cardiac performance, but it appears to be linear or nearly linear in a large percentage of these studies. So that if you had about a 10 to 15% pulse pressure change without the application of PEEP, when you added 10 centimeters of water of PEEP in these patients with ARDS, not only did your cardiac index decline, but it declined by about 10 to 15%. In the second study, these are septic shock patients. They made multiple measurements, so the typical static measures that we talked about, CVP and pulmonary artery occlusion pressure, but also looked at systolic pressure variation and pulse pressure variation. They took these measures prior to giving volume, and then after 500 cc's of 6% head-span. And what did they find? Very similar to the prior study, except now in a positive direction, that if the baseline pulse pressure variability was between, let's say, 20 and 30% there on the x-axis, not only did that predict that the patient would respond to the fluid challenge, but again, they respond in a linear fashion with a 20 to 30% improvement in cardiac performance as measured by the cardiac index. And you can see here again the R square is 0.85. They also developed ROC curves for these patients, and just to explain how these curves work, the more of that box that's included, the better the test is in terms of its negative and positive predictive value. So when you looked at right atrial pressure or pulmonary artery occlusion pressure, it only includes about 50% of the area under the curve. It's really no better than flipping a coin in terms of predicting whether or not the patient will respond to a volume challenge if you know the right atrial pressure or the pulmonary artery occlusion pressure ahead of time. Systolic pressure variation was a good test. On the other hand, pulse pressure variation was almost a perfect test. And if you used a discriminant value of 13%, and that's going to become important when I show you the algorithm that I've developed for our intensive care unit, that's kind of where the number comes from. The area under the curve is 0.98 with a sensitivity of 94 and a specificity of 96%. So there's almost no clinical test in medicine that has this type of predictability. These are data that we developed trying to highlight this relationship between stroke volume variation and stroke volume. And we use two separate technologies, one that looks at the arterial pulse waveform, and the other one, the more commonly used, thermodilution. So the variation looked at the arterial pulse. The stroke volume was measured with a PA catheter using thermodilution. And again, you can see in our 84 patients that there is this inverse relationship that as the variability goes down, the stroke volume goes up. And that's the physiology that we're going to exploit in the algorithm that I'm going to show you later on when we're treating patients in the ICU. The higher the variability, the more likely the patient will respond to volume. We also were able to develop the Starling curve, right? Patient in the left-hand frame there, end diastolic volume versus stroke volume. And simultaneously, we were measuring stroke volume variation and, again, stroke volume. And you can see, so the left frame is a typical Frank-Starling curve, preload measure, cardiac performance measure, gives you the mirror image of what these newer variables, stroke volume variation, gives you. So again, as the stroke volume variation comes down, now in the right-hand frame there, going from A to B, during volume loading, the stroke volume goes up. So we're familiar with this Frank-Starling curve. These data basically can show you the same thing using this dynamic variable, stroke volume variation. We've also looked at using this technology to remove fluid or to figure out where the optimal position should be for any patient in our ICU who's receiving renal replacement therapy. Obviously, we no longer have urine output as a marker of perfusion, and so we need some other markers. So in this study, we looked at either delta hematocrit during fluid removal or stroke volume. And our hypothesis was that increases or decreases in blood volume during a dialysis session, and primarily we're trying to remove volume, would show up looking at a cardiac performance measure. So we use these two different devices, one which measures delta blood volume on the left. The one on the right looks at cardiac performance, cardiac output, stroke volume, and stroke volume variation. And what we were able to show during a dialysis session, as we remove blood volume, so it's a decline in blood volume, so delta blood volume is negative here, was similarly mirrored here by the decline in stroke volume index. Two different technologies showing the same thing. We're more comfortable being intensivists looking at stroke volume, but we're getting a little bit more comfortable looking at blood volume when we see this type of relationship. And the R squared for this particular patient was 0.86, so a very high correlation between removing blood volume reflected by stroke volume index or compared to delta blood volume looking at delta hematocrit. So to kind of summarize, what we do in the ICU around fluid therapy, it's difficult for a lot of these patients to determine what optimal fluid therapy is, what's their optimal volume status, even, basic vital signs, what blood pressure should the patient have, can be difficult. CVP, wedge pressure is unknown in terms of where an individual patient should be. And other cardiac performance measures really have not held up to say that if your patient's above a certain cardiac output, they're going to do well, and that you should do something to get them up there. And the possible exception may be acute lung injury, where there have been targets for CVP and wedge pressure that have been shown to improve outcome. They don't improve mortality, but they improve outcome in terms of length of stay. And I'm going to talk a little bit about that as we get further into this. And since I work in a fairly opinionated group, it's hard to get us to agree on most things. But in general, for sick patients, I think most of us agree that optimizing cardiac function is a desirable goal. And these dynamic variables, pulse pressure variability or stroke volume variation, will facilitate this. The major take-home message from what I want you to get out of spending some time watching this presentation today is that these measures are inversely proportional. Stroke volume variation and stroke volume are inversely proportional. If you look at them together, you can really gain a lot about how to treat patients who have a clinical problem. If stroke volume variation is elevated and stroke volume is low, so you need to look at the pair, stroke volume likely can be improved with volume. You do need to consider the things that may impact the variability. We talked about some of the things in terms of spontaneous breathing, cycle length, and I'm going to show you some studies about that, but also dysrhythmias. If the patient has a varying R to R interval, and atrial fibrillation is probably the best example of this, the heart is going to fill at different time intervals, and the variability in stroke volume will be very high in those cases and will not allow you to predict whether or not the patient will respond to volume. Also, it's important to recognize that the converse may not always be true, and that some patients whose stroke volume variation is low, and again, I use this cutoff of 13% because when you look in the literature, somewhere between 10 and 15% provides the best discrimination when you're looking for a discriminating variable. Some of these patients may also be volume responsive, and you need to then consider things like the delta pleural pressure, the patients being ventilated at very small tidal volume. That will impact that. What's the lung compliance? And how are the heart and lung interacting in this individual? All these things will impact this. We can get around this to some degree through the use of challenges, which I'm going to talk about in several slides and several experiments that have been done. You can challenge the patient with tidal volume, increase the tidal volume to maybe bring out some what we've termed recruitable stroke volume, so where the variation may be low on a small tidal volume, but that will increase as you increase the tidal volume. You can raise the legs, which is similar to a 300 to 500 cc fluid bolus, and assess the impact of that maneuver on cardiac performance as measured by stroke volume or cardiac output. Or you could simply give volume, which is kind of a time-honored thing to do for sick patients in the ICU. In working in the intensive care unit, we like to do these bedside experiments, and you can really get the results immediately, get immediate feedback. So here's a study that was in critical care medicine by Monet and Pinsky back in 2006. Looked at septic shock patients who were mechanically ventilated in the intensive care unit, and they simply raised the legs when they thought the patient should be given a fluid bolus. So they got a bunch of baseline measures, raised the legs, took the measures again, so they looked at cardiac performance primarily, and then gave a volume challenge. So they did two things, raise the legs, then give volume. And in between all of these maneuvers, they looked at cardiac performance. And interestingly, the effect of raising the legs was fully developed within 30 seconds. That's something I learned from reading this study. And the bolus was given over 10 minutes. And you can do this with the beds that are in the ICU today simply by changing the bed position. So this saves the back of the nurses and the fellows and the residents who might be rotating through your ICU, who we usually ask to raise the legs. So this is something to consider in terms of preserving your staff. But this is what they found, and they measured stroke volume using an aortic flow probe. The dark circles are the responders, the open circles are the non-responders. So for the patients who responded to raising the legs, and there's about a 30% change in aortic blood flow, they also responded to the fluid challenge. So it's a way to predict ahead of time without actually giving volume if the patient will respond to a volume challenge. If you didn't respond to raising the legs, so those are the open circles at the bottom there, you did not respond to the fluid challenge. And they looked at a stroke volume change of 10% as being clinically meaningful when they raised the legs. And if they used that as a cutoff value, the sensitivity was 97% and the specificity was 94%. So again, raising the legs as a clinical maneuver that you can do when maybe the variability, because of some of the other things we talked about, how the patient's breathing, what the tidal volume is, doesn't tease this out, is a good way to assess whether or not your patient will respond to volume. And the beauty of it is it's rapidly and totally reversible. If the patient doesn't do well with it, you just put the legs down. I'm going to spend just a couple of slides now talking about the effect of varying the tidal volume, the respiratory cycle length, and measures of cardiac performance, basically related to heart compliance and rate, that will also affect pulse pressure and stroke volume variation during positive pressure ventilation. And this is a study by Kim and Pinsky that was in Critical Care Medicine in 2008. They used dogs, they were anesthetized, they used thermodilution, cardiac output, and the PICO device to look at the arterial waveform. And then the dogs were mercifully killed with pentothal and potassium chloride. So if you looked at pulse pressure variation versus cycle length, so these are the number of respiratory cycles per minute, you could see in this graph that the cycle length actually impacts the pulse pressure variation. So the more respiratory cycles per minute, the higher the pulse pressure variation. And again, this is exactly what you'd expect, because as the pleural pressure is changing, the loading conditions on the heart are changing. The asterisks above the first four show that there's a difference, statistically significant difference, with that type of cycle length versus the higher cycle length. Same experiment looking at the impact of varying tidal volume, and now looking at two variables, pulse pressure variation and stroke volume variation. And again, you can see as you go up on the tidal volume, it has an impact on both of these dynamic measures of fluid responsiveness. So these are things you need to be thinking about at the bedside in terms of how you're ventilating the patient and whether or not they may respond to fluid. This is an experiment in anesthetized dogs. When you're looking at the ICU, it's usually a clinical question that's driving you to come to the bedside to sort through this. So these are all the things I want you to consider when you go to see a sick patient who the question comes up, does this patient need volume? And the common question that we get asked relates to blood pressure and urine output. And finally, in the last experiment they did, baseline being the first bar graphs there, looked at volume loading, dobutamine, catecholamine, inotrope, or esmolol, and the impact of those therapies on either pulse pressure variation or stroke volume variation. So as you would expect, when you give volume, pulse pressure variability and stroke volume variation both decreased. As the dogs were put on dobutamine, increased their heart rate, increased their force of contraction, variability went up, as you might expect. And as you gave a beta blocker, esmolol, you also saw that there was a decline here, not as pronounced as giving volume, but importantly what this shows is that your therapy impacts these variables, and all these things need to be considered when you're considering this treatment at the bedside. What therapies are you giving the patient? Because it really impacts where they are on their own Starling curve. So the first challenge was raising the legs. The second challenge is changing the tidal volume. And these are ones that we commonly employ at the bedside at Bay State Medical Center where I work to try and tease some of these things out when we get asked a clinical question for either the oliguric or hypotensive patients. So this is an example of what I've termed recruitable stroke volume. Patients initially ventilated at 400 cc tidal volume, rate of 20. Stroke index is 35, so approaching the normal range. And the variability is 8 to 10. And we came to the bedside in this particular case because the patient was oliguric. And with lots of other inputs, right, everything else we know about the patient, we're not solely looking at this data. We thought maybe the patient would benefit from volume. These data don't predict that. So what we did was we increased the tidal volume up to 700 cc's. We dropped the rate so the patient wouldn't get too alkalemic. Stroke index didn't change very much, but the variability more than doubled. Patient then got a fluid bolus of 500 cc's over the next 15 minutes. We went back to the original ventilator settings, and the stroke index increased by over 30%. So this is a way to tease out whether or not the patient will benefit from a fluid challenge where stroke volume variation may not tell you that because of the way we're ventilating the patient. And this is probably a patient with acute lung injury who's on a low tidal volume strategy. Now, there's been some science applied to this in terms of how much does a tidal volume actually impact stroke volume variation. I showed you the experiment by Dr. Pinsky. This is going to actually show a very similar thing. These are septic shock patients, and the differentiating point that they used in terms of tidal volume was 8 cc per kilo. So the low tidal volume, the left-hand panel, is less than 8 cc's per kilo. The high tidal volume is greater than 8 cc's per kilo. And then the patients ultimately were given a volume challenge, 500 cc's of normal saline. 40 patients altogether. Those are the individual numbers of patients in each study. So you can see the impact of tidal volume directly on pulse pressure variation as the tidal volume goes up, just like the experiment with dogs, just like the experiment I showed you in an individual patient, the pulse pressure variation changes. Interestingly, the amount of volume that you see in terms of fluid responsiveness also changes. And I'm going to show you that in the next slide. Really what this shows is that there's a linearity of response here. And if you go back to the earlier slide when I looked at cycling the ventilator and positioning the patient on their Starling curve, at the lower tidal volume, the difference between the two blue circles there is the pulse pressure variation. So you don't see a lot of change on a low tidal volume. You don't see as a significant response in cardiac output, which is being measured there on the y-axis, goes from about 5 to 10% change, compared to when the patient's on the higher tidal volume. Not only is the pulse pressure variation greater, but the response to the volume challenge is also significantly greater, an 18% improvement in cardiac performance compared to a 7%. So you can kind of tease these out by varying the tidal volume. And again, it really depends on what the clinical question is. You're going to the bedside because there's a question about the patient's fluid status. So if you kind of put all that together, what are we saying is that arterial waveform analysis during positive pressure ventilation predicts an individual's position on their own Starling curve. So as Guyton showed us, and hopefully I've showed you in this last series of experiments, there's lots of variation in where an individual patient may be, not only on one Starling curve, but going from curve to curve. If you superimpose stroke volume variation on these series of Starling curves, if you're up there on the top, what you would expect is the variation to be low, and if you need to improve cardiac performance, probably something other than volume is required. And if you're down there on the left-hand side, the variability typically will be high, and these patients will respond to changes in preload. So that's the hard part, and I'm really going to spend the rest of the time talking about how we use these data at the bedside in our intensive care unit. And I'm going to spend a little bit of time on the FACT trial, the fluid and catheter treatment trial, which looked at volume therapy of the patients with acute lung injury and ARDS, because we enrolled about 100 patients in that study in our ICU, and show you really how complicated that experiment was and how you might be able to simplify it using some of this data that we've just talked about. So if you're going to put these two things together, this is the algorithm that we've developed and used in the ICU, and usually the clinical question has to do with blood pressure, the patient's hypotensive, or oliguric. So again, there's a clinical question that brings you to the bedside. If the SVV is greater than 13%, we consider that patient to be volume responsive and give volume. If it's less than 13%, we predict that the patient won't be volume responsive. And then we look at the stroke index and then put them into a category which would determine whether or not the patient would get a vasopressor, an inotrope, or even possibly a diuretic. So I'm going to talk about the right-hand side here, the patients that are not volume responsive, and the clinical scenarios with normal, low, or high stroke index that we're all familiar with and when you might want to use one of these specific therapies. So again, for the non-volume responsive patients, if the patient's fine, you do nothing because you're not going to make them better. So again, a clinical question really drives this, and the stroke index now would really direct the therapy. So if the stroke index is normal, perhaps a pressor is indicated, and for patients with clinical vasodilation, severe sepsis or septic shock being the ones we most commonly deal with, certainly that's reasonable therapy. For those patients with a low stroke index, perhaps an inotrope or maybe even a vasodilator is indicated, who has a low output state. So clinical congestive heart failure would fall into that category. And then finally, and I'm going to show you a couple of examples of this, if the stroke index is high, patient with acute lung injury or prior massive resuscitation, perhaps a diuretic would be the appropriate therapy. So just want to talk about the second pathway in a little bit more detail because I think this is one that people have problems with, inotrope vasodilator. If there's no further response to volume, so it looks like their stroke volume is no longer responding to fluid, so on the flat part of the Starling curve, or they have clear lungs, it's pretty easy to give fluid, right? You're not going to hurt the patient. On the other hand, you can simply raise the legs, and we do this more commonly in patients with acute lung injury or acute kidney injury, where an inappropriate volume challenge might be detrimental. This is a way to give a reversible fluid challenge. If the stroke index goes up, certainly you can give more fluid in that setting. Just to get back to the FACT trial, because we found a tremendous amount of utility for looking at simply stroke index in patients with acute lung injury. This was published in 2 sequential issues of the New England Journal back in 2006. What did they find? They found that optimal fluid balance is good. Dry was better than wet. They used a CVP of 9 and a wedge pressure of 13, so less than that, the patients did better. CVP monitoring or pulmonary catheter monitoring was equivalent, and that was the unstated goal of the study, I think, really was to try to minimize the use of pulmonary catheters in a disease where a lot of patients thought it was very important. Neither was good at predicting optimal fluid balance. There was no mortality difference whether or not what type of catheter you got or whether or not you were wet or dry, but length of stay was impacted, and length of stay does have a cost impact on our patients and on the hospital's viability. And interestingly, or maybe not, mortality was not related to fluid therapy. Surprise, surprise, with a very complicated disease like ARDS. The understated outcome of this study, I think, which really was not emphasized in the articles or the editorials, was that diuretics, and basically they used Lasix in this study, was useful in acute lung injury. And there was a real difference, about 1 liter a day over the course of a week in the patients that were in the dry arms of these studies, and they got that way by using Lasix. And paradoxically, or maybe not, there was no increase in renal failure for the patients that received lots of diuretics. This is a composite algorithm, and I certainly give the nurses a lot of credit for being able to follow this. All the numbers and letters there in the little boxes, once you could put the patient into the box, prescribe some specific therapy. So this is not an easy study to follow. Patients were in it for a minimum of a week or until they came off the ventilator, and it was these measures were made every 4 hours. The way we've applied looking simply at stroke index now to these patients, if the stroke index is high and the lungs are wet, we are now diuresing these patients, and we feel pretty comfortable doing that since the publication of this trial. So that's, again, the extreme right-hand side of this algorithm when you're looking at those orange boxes. If my patient has acute lung injury and a high stroke index, they get diuresed now. So I'm going to finish up by kind of going through a series of cases that really highlights the algorithm that we've introduced now. Try to show you exactly how we use it in our ICU. So this is kind of a typical patient, 64-year-old male with the typical comorbidities, diabetes, hypertension, COPD. He's at rehab. He's had an amputation about 10 days ago. He returns to the hospital, short of breath, febrile, in shock, tachycardic, and tachypnic. His chest exam is diffusely abnormal, belly soft. He has a well-healed wound and some erythema and cellulitis on the non-amputated side. His chest x-ray shows what you might expect. He's got an ALI or acute ARDS type of picture, bilaterally abnormal, high white count, left shift, high anion gap, acute kidney injury. He's got respiratory metabolic acidosis with hypoxia and a left bundle branch block. So critically ill patient, lots of possibilities here in terms of what's going on with the patient. but certainly looks at least septic. Maybe he's having some acute coronary syndrome. Maybe his x-rays pneumonia, fluid overload, or ARDS. As is typical, Saturday at midnight. And again, he has complex physiology. He's in shock, on Levophed, not making urine. Gets a pretty good resuscitation, 1 liter an hour for the first 8 hours. And as I said, this is the patient you're concerned about volume because he has acute kidney injury. He's got a very abnormal x-ray and a very high AA gradient. If we look at the stroke volume variation, it's still elevated after 8 liters. The stroke index is low. He gets 2-liter bolus rapidly. The variability comes down from 24 to 17. The stroke index goes up from 22 up to 30. When you plug him into the algorithm, he's in the volume responsive side, 24% variation. He gets fluid. He was still elevated at 17%. He gets more fluid. Variation continues to come down. Now it's 14%. Stroke index is up to 38, so basically normal. Starts making urine. However, he's still over here where the algorithm would say to give volume, and he gets more volume because of that. If you kind of look at his data over time, this is over 7 minutes as one of these liters go in. You can see in the top panel, which is cardiac output, his cardiac output goes from 3.7 up to 4.9. His stroke volume goes from 31 up to 41, and the variability of his stroke volume comes down from 31 down to 12. So exactly what you'd like to see in a fluid-responsive patient. As I said, 2 more liters were given. Stroke volume variation is now down in the single digits. Stroke index is clearly normal at this point. Still making urine, still on pressors. Clinical diagnosis, vasodilated septic shock, so that makes sense. Stroke index is normalized. It maxed out up around 58 cc's later that afternoon, and we started giving this patient diuretics immediately, even though he's still on pressors, based on this physiologic parameters that shows us that his heart performance is excellent. And this is an example of timely resuscitation in a very difficult patient without using a PA catheter. If you kind of go through where he was at different times in his illness, once his stroke index normalized, clinical diagnosis, septic shock, feel very comfortable now that I have this cardiac performance measure, putting him on a vasopressor. Later on, he's always had a wet chest x-ray, but later on his stroke index was very high, and we start diuresing him really immediately at that point, even though he was still on vasopressors. Ultimate outcome, he went home, a week on the ventilator, creatinine peaked at 3.3, and no other organ failures. Here's a second case, 54-year-old female, peripheral vascular disease, claudication. Is having elective AAA repair. This is a redo operation. Gets pretty significant resuscitation in the operating room because of some technical issues. 8 units of PAC cells, 12 liters of crystalloid. Comes up to the ICU on Levophed, vasopressin. Thank God she had a Doppel pulse on both sides, and the last note we saw was transferred to ICU in stable condition. She was anuric, on pressors, awake. She had clear lungs, already had anasarca. This patient walked into the hospital that morning for day of admission surgery. Tachycardic, hypotensive, on the ventilator. The stroke volume variation is elevated at 17%. Stroke index is low. So again, she's over here in the algorithm that predicts that she will respond to fluids. She gets 2 liters rapidly, 4 units of FFP, 10 pack of platelets over the next 30 minutes. The variability comes down to 7%. Stroke index goes up to 29. Heart rate comes down. With this data, I feel pretty comfortable giving her actually a beta blocker at this point, which helps her stroke index by slowing her heart rate. But she's still requiring pretty dramatic amount of volume, and as soon as the bolus is in, her stroke volume variation goes up, her stroke index drops, her heart rate goes back up. She gets another 6 liters of fluid fairly rapidly here. And each time she gets the therapy, you see this transient improvement in her stroke volume variation coming down and the stroke index going up. She looks really like a class 3 or class 4 ATLS designation of hemorrhage. She's got 9 liters in 3 hours after 12 liters in the operating room, has this kind of cyclical class 3 to 4 hemorrhage type of response. Remains on pressors. Call the surgeon. She goes back to the operating room. And unfortunately, this is what they find. I think clinical assessment here certainly is adequate, but it's nice that this data showed us exactly the same thing that we would have anticipated clinically. So it shows how the physiology kind of matches the clinical assessment. And finally, we've been using this dynamic variables of volume responsiveness to remove fluid from patients. And this is an example of a patient, clinical septic shock, got aggressive volume resuscitation early in the course, which is typical, was on pressors, acute lung injury, also had acute renal failure and required dialysis. And this is one of the patients that we showed you earlier who was in the CVVH study. Got better rapidly with volume, antibiotics, and organ support. On the other hand, the lung function remained poor. Patient remained on the ventilator, and X-ray looked terrible. So exactly what you would expect from a massively resuscitated patient with acute renal failure. There's the X-ray, basically a bilateral whiteout. If you look at it, the hemodynamic data we developed, the cardiac index is actually very good. Stroke index is high. The variation is low. And you look at the unindexed values, also show that the patient is very well resuscitated. And we've tried to coin this term, de-resuscitating the volume overloaded patient. The patient is ready to devolve. So we're going backwards now in terms of applying the algorithm to remove fluid. And this patient was getting CVVH, so we had a great mechanism to take volume off. And we did it really based on trying to go back to those targets, primarily for cardiac performance as measured by the stroke index. So again, stroke index is very high in this patient. This patient was getting volume removal via CVVH. And we were able to get that patient off the ventilator about 5 days later with a tremendous amount of volume removal on a daily basis, looking at stroke index. And we felt comfortable doing that, certainly since the publication of the FACT trial. So to sum it all up, one thing I'd like you to take home with you today is for those patients where there's a clinical question, and again, the ones we most commonly get asked are hypotension or oliguria, and now we found a lot of application to remove volume in patients with acute lung injury or previous massive resuscitation. You can plug them into this algorithm and really see which pathway they fit into using all the clinical parameters that you would on top of this algorithm. The algorithm is going to help you, but it's not going to get you there all the way. So using these dynamic variables of fluid responsiveness individualizes a Starling curve for your patient, and I really think that's the beauty of this. And volume responsiveness then reflects this basic physiology. I want to finish with a couple of slides looking at, we talked about flow and fluid responsiveness. Now we're going to talk about perfusion by looking at O2 extraction. And I learned this from Dr. Pinsky because I've always had this interest in hemodynamic monitoring. And so what's the purpose of all these things that we measure in critically ill patients? This is what he said. To determine if cardiac output is keeping up with tissue O2 demands, and if not, to determine what components of the profile need to be adjusted to reestablish this consumption-demand balance and achieve the optimal cardiac and mixed venous O2 reserve. So there's a way to look at perfusion using O2 extraction data to tell if the level of flow is adequate for an individual patient. And we really want to focus now really on the middle part of the algorithm, because I think the other parts are fairly straightforward. If the patient needs volume, you give them volume. If they're fluid overloaded, you can diurese them. But the concept here is a normal cardiac performance or a low cardiac performance adequate for your patient? And sometimes that's very hard to tease out, and this is where O2 extraction data can be very useful. If O2 extraction is high, the patient probably needs better cardiac performance, better delivery of oxygen. If O2 extraction is low, improving O2 delivery probably can't help that patient. And it'll help you to determine, what to do next. Is it worth trying a fluid challenge? Does the patient simply need pressors at this point, or is an inotrope indicated for the patient who clinically has heart failure? So again, we're just going to focus really on the middle here, looking at O2 extraction through this measure of SCVO2, so the saturation of blood in the superior vena cava, to determine if the level of oxygen delivery is adequate for the patient. And this is what we all remember from our first couple of courses in physiology. And when I ask my residents or fellows to reproduce this, sometimes it's difficult. You can really kind of simply look at O2 extraction this way. We're removing the cardiac output and hemoglobin portions here of O2 delivery, but we simply look at arterial sat and the amount of oxygen then that's left in the superior vena cava. The difference then being what's taken up by cells. And this is the way we use it, and there's a tremendous amount of data going back now over 10 years looking at, what should we do with oxygen delivery, and does manipulating oxygen delivery help particular subsets of patients. So there's no evidence or known benefit to increasing O2 delivery, cardiac output, arterial O2 content. And there may be harm, and that's what some of that data showed, that putting patients on inotropes may be detrimental when extraction is normal or low. And again, you have to be comfortable with these numbers, but up to a third is probably okay. Organ failure and mortality can still occur, but it's probably not related to an O2 delivery problem. There may have been a prior deficit that caused the organ failure, but if extraction is low, it's probably not present now, and there's probably nothing you can do about it. On the other hand, when extraction is elevated, and again, this is a number I like to use, but over 40%, vigorous efforts to increase O2 delivery should be employed and may improve outcome. And I think this is what intensivists and surgeons and anesthesiologists and emergency room physicians do every day. It's the basic resuscitation paradigm. We're going to increase O2 delivery because it's obvious. And I think we all believe that that's useful. So if you kind of tie it all together, here is a patient with septic shock, acute kidney injury, acute lung injury over a time span of about 5.5 hours, where the patient's getting kind of the typical therapy, volume, vasopressors, and antibiotics. This patient also has lots of PACs, so the variability data, which I've highlighted in red there, doesn't really predict fluid responsiveness because they're having a varying R to R interval anyway, so the heart's filling at different time intervals related to the PACs. But if you simply look at the cardiac performance measures, cardiac index and stroke index, you can see with the volume resuscitation that those are both increasing. At the same time, when you look at the saturation of blood in the superior vena cava, saturation is going up, the extraction is going down. So I feel very comfortable with this patient in terms of where they stand, that the level of perfusion based on these measures of cardiac performance are adequate because the O2 extraction now has come down to 30% or less. So if I look at a cardiac output of close to 7 liters per minute and a superior vena cava saturation of 76%, the converse, about a 25% extraction, so something we all would agree is normal, those values are very reassuring that I've done what I can in terms of resuscitation, and now I can start thinking about some of these other things that really impact patient outcome. So this is how you put the measure of flow, cardiac performance, stroke volume, cardiac output, stroke index, together with perfusion, how much oxygen is being extracted out of the blood, to tell me, do I need to do anything about O2 delivery, or is that part taken care of? And now I'm satisfied that basic resuscitation is accomplished. I've optimized the hemodynamic therapy. I can monitor the therapy and these outcomes continuously if I choose to. It assures that I can do it in a timely manner. And a rare patient dies from a correctable DO2 problem. And I think that's true for most of us that work in the critical care settings. And now we can move beyond these questions of hemodynamics to figure out what's really happening with the patients. And that's where I'd like to end it. I don't know if there's any way for people to ask me questions. But the final conclusion is the variability in stroke volume, and again, during positive pressure ventilation, most of this data has been obtained, is a better predictor than traditional measures of volume status that a patient will respond to a volume challenge. And simply, the greater the variability, the greater the predicted response to a volume challenge, and interestingly, that response is linear. Thank you.